the most important picture. I missed to show it, which is Harvey Cushing. That Professor Ed Lowe's like it very much. He has a nicer one than mine color one. And I mentioned about the little mini from New York. That was the first case Dr. Cushing diagnosed with this basophilic tumor. And in 1912, 20 years later, as I mentioned, the group in Oxford, where Dr. Sanjiva is coming from, has reported similar cases, and they tagged the name as a credit to Professor Cushing to call it Cushing disease. One more thing, comment on the previous discussion. You see, conversion of a procedure from one to the other is not religion. You can still do it, and you should do it, and you should be embracing a new technology, but eventually adopt what is fit in your practice. That's my message. There are different issues, chronicle, they have been mentioned by the previous speakers, but something related to Cushing disease. You see, adrenal cortex was 1855 was first described by Edison. And there were many discoveries and nomenclature came over the years from Nelson syndrome, cortisone discovery. They are all important in the history. Where on the surgical part, transgender surgery, we have been listening for the last 3 days from the new endoscopy committee and from my committee here with about the evolution of the procedure from Stoffer all the way to Dr. Julius Hardy, where he coined the procedure transgender surgery, and he coined in 1968 the microadenoma, which is an essential part in the diagnosis of Cushing disease. But on the endoscopic part, of course, Gio was an avant-garde in our book for the endoscopy. There were many others. And I put Hardy's name, although he was not an endoscopic surgeon, but I recall when he came to Vienna to celebrate the 100 years of pituitary, he came and he said he has an endoscope for $1. And he raised that small mirror from his pocket and said, "This is my endoscope." We start all laughing. But at that time, it was a valuable tool. And I remember we used to use it to look for the tumor up in the suprasellar area if there is any residual. And I'm sure Dr. Ed Lowe's and Dr. Farbush and Fred, they knows about this one. Of course, the endoscopy, I like to thank the group from Pittsburgh and Napoli. They were the avant-garde in promoting this technique. Two credit comes, one to Professor Hardy, coining microadenoma. And this make a difference in the management of Cushing disease. As we know, Cushing disease in general, they are microadenoma rather a macroadenoma. And somebody was neglected completely, but I like to put his name. He is from Bristol, Professor Griffith. He is the one who published in 1987 the direct approach that we are all using it. To avoid all the complication from the septum, for septum perforation and integrity of the mucosa and the nasal cavity. Professor Griffith was a great guy, but a humble person from Bristol, and I'd like to give him the credit on these things. Cushing disease, of course, we have to categorize in pediatric. Is not like in adult. Most of the cases in pediatric, they are more aggressive. They are macro, more in percentage. They don't have the gender difference, where in adult is completely the reverse. There are different criteria to make a diagnosis. I'm not going to go over this. Surgeons that don't like to listen this one, but I always say a good pituitary surgeon should be a good endocrinologist. If you don't know the pathophysiology and the physiology and the feedback of all these hormones and their relationship, you won't be making the right judgment for immune management. The same like you should have be a friend of the ENT colleague, you have to be a very close friend because they will supply you with the case, and you should have an aggressive endocrinologist and minimal invasive neurosurgeon. And there are different diagnostic tool, they are give you, you see, the sensitivity and specificity of all these overnight suppression tests. They give you a percentage of 90 to 100% specificity. And more recently, we heard that there is even the saliva cortisol test 8 hours after the suppression test. It gives you a higher sensitivity. It might be the future. But even with all these lab tests and SCTH, imaging, although is condoned sometimes in Cushing disease, in microadenoma, there are a percentage, at least in some report, up to 30% you cannot see the microadenoma, and you have to be dependent on some lab studies that I will talk about it. But again, there are different radiological images to make a diagnosis of microadenoma. And this is, of course, pituitary is one of the P's that has no B's. And that's what I teach my resident. This is the pineal region, the pituitary, the plegia postrema, they don't have blood-brain barrier. So you advise your neuroradiologist or the radiologist to do the imaging immediately post-injection so you can spare or show the microadenoma. There are different modern technology to show it with the molecular imaging now, more recently and trendy. Anatomy of the sinus is very important. That's the value of CT scan. Here on MRI, you see the septi within the sinus, they are not always a midline. There are different septi. That's why I still believe the main point mentioned, the landmark, and reported as mentioned several times today, and Lowe's mentioned midline structure is very important. You should not lose it by the orientation. That's, I still believe myself, I'm against all the odds. I still like to go through the rostrum and midline. I don't like to go through the ostium. The ostium is not a good landmark to start with. The ostium, you have to lift a little bit the superior turbinate to see it. You are coming more lateralized, you see part of the cella. Where if you go midline, this is the actual midline, and then you can extend it to from one ostium to the others. Especially when you are doing a recurrence. There is no ostium. The ostium has gone with the wind. No, you drill it. So you have to go to the midline, and the nasal crest or the sphenoid crest is always there as a midline. You keep it as an orientation. And you see here the chamber. If you go in the right chamber or the left chamber here, you are ending in the cavernous sinus before you start even on the lesion. And the lesion is just here next to the midline, next to the medial wall of the cavernous sinus. And you see it is very small lesion in this one. You have to recall as well, there are several reports, and we reported that it's not always within the cella. Sometimes is infracellular, sometimes behind the stalk, sometimes on the medial wall of the cavernous sinus or under the diaphragm. And in the old days, I say, what is the need for the endoscopy in Cushing? I can do it without. But I realized the evaluation of the gland and seeing the gland from near vision, you might be able to discriminate sometimes, and it helps you. Or to see this blind corner with the endoscope if it's needed. So we use the PET scan in the negative MRI studies, and we realize 25% of an MRI negative Cushing disease documented by lab studies, but we failed to lateralize, we were able to have a positive PET scan. And I think the daughter of Professor Miguel Reyes has worked on this one even more advanced than me, because I remember attending her presentation last year in Malaga, and she showed even a more updated result on this one. So remember, if you have the facility and you fail to lateralize, then it's very important study if you don't want to go into invasive procedure. Inferior petrosal sinus sampling is a technique we've approached it when we fail to identify, to lateralize. It's as published by the NIH, gradient more than 3 is a lateralizing one, and it can be a centralizing one, and you can discriminate it from the ectopic. But remember, sometimes you get contamination from the contralateral side. The intercavernous sinuses, they can be very prominent. You contaminate from one sphenoid sinus, petrosal sinus to the other side, and you should be aware of it. And you should have a good interventional radiologist that he put the catheter in the right spot. Otherwise, if he put it in the jugular bulb, you are contaminating from the other side, and the results are not counted. So this is the challenge in exploring a pituitary gland where there is no visual adenoma on MRI. So it's a technical challenge because you have a small cella, you need to expose the whole pituitary gland. This is a very important part in Cushing disease. And of course, you have to deal with the bleeding from the basal dura and from the cavernous sinus once you manipulate it. Abnormal tissue sometimes is difficult to recognize, but in several recent reports that the endoscopy with the near vision, it might give you some discrimination by visual impact. So the goals of operation that was described in Cushing disease, there are two specific things. You have to be selective in the resection, not ablation of the gland. And the other things is the preservation and restoration of the pituitary function to the maximum. Of course, all others apply to all pituitary tumor because Cushing, as I said, they are usually micro, but decompression of the optic is one of the options. So if you do the right job and you do selective resection, that's what you get. This is pre and post. You see, this patient was reported as partially empty cella, but we saw that small lesion and we highlighted on PET scan. This is pre and this is follow-up 5 years later. Now, when it comes to the challenge of the approach, this is the big discussion, microsurgery, endoscopy. I always say all the road goes to Rome. And I stress the point, I like to go through this silly nose, the nasal crest. This is your midline. Don't go through the windows, through the eyes, because especially in the recurrence. And this will be really least invasive because you don't need to touch even the septum. At the back of the septum, you do your incision if it's needed just to make a flap. And you decide about the mucosal septal flap to the size, you tailor it yourself. And then you deflect the septum to the other side. I have staged the procedure, the transfemoral surgery, into 4 phases. I call it the nasal, sinus, cella, and paracella, and the supracella. This is the stages I stage the procedure. And this is a small technical note I have improvised. One thing I have to say, and I stress it over the years, using the speculum is not a sin. I have never had problem with the speculum. People, they make a big fuss about using the speculum. I use it at the beginning because I open the door for myself. I do the incision on the posterior part of the septum, make the mucosal flap. Then I displace the septum to the other side, and through the contralateral nostril, I pass a dissector, penetrated dissector, and I enter the scope. You see the tip of the scope here, I know I have my scope. Then I remove the speculum if I don't need it, okay? But it's nothing wrong by using the first phase, phase 1, I call it, the speculum. You will do with your 2 hands, free by dexterities. I do the draining here through the endoscope as I did it here. You see, I'm seeing it from the endoscope. I use my 2 hands, okay? And I do the flap, and this after resection, I can see the herniated this. You see the exposure I'm getting even for the speculum. This is with the speculum, but I put the endoscope to show you what I have taken by putting the speculum. And this is at the end of the procedure. I see the middle wall of the cavernous sinus, and I see the elevated, retracted diaphragma celli. This is a small technical note. You are not damaging the integrity of the nose. I hate to do any manipulation on the turbinate unnecessarily, unless you are doing an extended approach, and I don't like this extended approach going in the cavernous sinus. I've seen several reports and several videos from the last 3 days. People go into cavernous sinus, take 10% of that lesion and leave the 20%. And what is the outcome? Underreported. I'm sure cranial nerve involvement. I'm sure there are the vascular injury I've seen over the last 3 days. Everyone showed me 1 or 2 cases of carotid artery injury. I have never witnessed this one in my practice with the practice we are using. Navigation is essential, and I agree with the point mentioned. Now we never use the C-arm unless you don't have the navigation. But I think most of the places they have a navigation system, and it's very essential, especially in the recurrence cases, because you got lost. you need the navigation system. Now, the beauty of the navigation, of course, you are not doing interaxial lesion to say, talk about the shift and all these things. You are talking about skull-based lesion that is vessel on the skull base. So the shift is not a big issue in that regard. Thanks to Dr. Cababianca, who has supported and promoted the endoscopy, and I always like his books and the nice picture he showed. We used them here to show the value of the endoscopy. I'm not saying that we should do the transfemoral surgery without endoscope, but I like the hybrid use. There is something called the third option. One option is purely microscopic, the other option purely endoscopic, but why not making the benefit of the two facilities? Both are tools, and I think these two tools joined together, the end result or the common denominator of the two techniques to do a microsurgical resection of the lesion. Use your two hands to resect, not only the suction, pulling and retracting, pull and counter, and do arachnoid dissection. This is very important even in transfemoral surgery. Someone told me, oh, in endoscopic, you don't need microsurgery. I said, then you are on the wrong side. You are not going to give good surgery. Special area to inspect and the value of endoscopy to look under to the medial wall of the cavernous sinus, to look to subdiaphragmatic area and peripituitary stalk, especially in microadenoma of Cushing, so you can retrieve any hidden lesion. And sometimes this lesion becomes like a horseshoe. One time we operated on one side and I thought I'm done. And there was a lateralization, a microadenoma. 2 years later, I have it on the other side. Then when I went back to the picture, I saw there was a horseshoe appearance of that small lesion going behind the stalk, hiding on the other side. So transfemoral versus micro, I call it the endoscopic assisted transfemoral surgery. And this is how you see it. You might see it flop or flip. You have to decide and make that decision like this picture. So endoscopic transfemoral surgery, people complain that this is 2-dimensional. You can compensate. I have a 3D with the microscope if I need the depth, but most of the time you will manage with the endoscope. And it was mentioned that there is now a 3D endoscope, but it has not got promoted or designed by the company and went further stretched for that one. It should be used by surgeon with good microsurgical technique. Otherwise, it's a failure. Potential for more industrial innovation. That's what I asked Dr. Cababianca. We should go more with the company to introduce more technology. You see, if you want now to zoom that endoscope, or if you want to focus on the scope, it's a nightmare. It's a mechanical and very harsh sometimes. And recently I talked to stores. They said, oh, finally they came with something like the BMW. You can move it from outside to zoom out and in, but it's still not very popularized in the market. A learning curve is a prerequisite, and we heard it several times. CSD was a concern, but I think with the mucosal flap and with the technology has improved tremendously. And I always say the combination is focused on microsurgical. This is a report from COVAX. Dr. Edlows knows him very well. They did the study and they divide them between microscopic and endoscopic. They found no result change in the remission for Cushing disease. Intraoperative, I don't see the indication for the Cushing disease microadenoma. It might be for a giant tumor, yes, but for Cushing disease, not. It's cost, perhaps not effective for many people. If you have the tools, I use it for giant tumor resection. What are the suggesting criteria for remission? One of the features is clinical feature, a resumal of diurnal variation. This is very important. It might take 6 months. And there are several criteria. I mention it here. This slide, I borrowed from your book, Dr. Lawrence. This is your book on tumor. I like that book you have done. I wish you have an update on that one. You published this one before the era of endoscopy. What was your result in remission in microadenoma? 85%. Not the best one can get this results with all the tools they have. But some of them, Dr. Falbush, his results is In the 80s was 80%. In the 90s, he just reported 2 days ago in his presentation, it goes 80 to 90% for microadenoma first time. So it tells you it depends on the experience of the surgeon rather than the tool. Whether you are using the microscope or endoscope, the difference is the variation not very huge. But where to dig and find the microadenoma, this is the most important. So are there alternative options for no remission? As mentioned, you go again because this is a surgical option, and in 50% you will find the adenoma on the second go. Okay, I mean, if there is no remission. Hypophysectomy, we get extended from it, but we are still do the multiple incision if we don't see the gland, and we do multiple vertical or transverse incision and see if we can dig the adenoma. Of course, radiation and bilateralectomy is another, there is medical treatment, but beware of these type. The pathological type became an important type of when to refer patient to radiation therapy. The silent cortical tumors, they are very aggressive. The Brooke cell tumor, they are rare, but very aggressive. Cavernous sinus wall invasion by the lesion and high MIP index has been reported above 3 plus %. Then there are potential for referral for radiation. Radiation has its side effects, and there are different types, but it has some value when we need it. There are reports that caprolactone, which we all use sometimes, my endocrinologist, anything he can give caprolactone, he said it might help. Even in Cushing disease, I doubt it. Ketoconazole has improved the clinical status, but not the hormonal profile or the size of the lesion, but they might work as a radioprotective agent, so it might interfere with radiation therapy. This publication came from Professor Ladislau Steiner from the Charlottesville Times, okay, and he has reported not very impressive result, but these are the results with the gamma knife. And of course, the comparison to surgery was not perfectly well because he was using the urine-free cortisol rather than the suppression test, and which is more sensitive. And the follow-up was only for 24 months. And there were visual issues, neurological deficits in 5%, cranial nerve deficits in 10%. Adrenectomy, there is a renaissance for, I call it, for desperate patient and doctors. When they fail all the medication, they go for the adrenectomy, and there is a surgical mortality, although they use now the endoscopic procedure to perform laparoscopy, and they will leave it for as an end solution. There are medical treatment, pasireotide, which is somatostatin receptor competitor, is very expensive. I think it's $100,000 for a 1-year treatment, where transgender surgery, I think in the state about $15,000 or something like this. So this is not in for average budget countries. So preservation of the gland, that's the second most challenging situation other than the localization, is the size, location, to see the tumor either on the images or during the surgery. This is one of the influencing factors. If you see it, the result is much better. If you don't see tumors, then whatever you do is not a good outcome. The preoperative function is another factor. We mentioned the pathology, surgical technique and experience. I'll stress this point. And the use of endoscopy, it will help see blind corner. Apoplexy can occur in Cushing disease. This is an interesting case from the long time. Professor Pierre Lagianis used to come to us, and we were discussing the case by chance. He's an interventional radiologist, and we were waiting for our gamma knife to be installed. And this patient has a Cushing disease. She doesn't want to have surgery, but all the lab referred to Cushing disease. Unfortunately, we didn't get the gamma knife. We got the Cypher knife, but 6 months later. By that time, See what's happened. This is the lesion, got apoplexy in it. This is the size of it after 3 months, 6 months, 9 months. This is auto-execution of the adenoma, of a Cushing ACTH producing adenoma. And then we gave Cypernaf to the small lesion. I'm not going to do surgery for the small area. Pituitary carcinoma, they are rare, but they can occur. They metastasize. We have this young lady, we operated twice on her transmural. There was a cavernous component, received radiation therapy, ended with metastasis to the ribs. And we gave her Timodal for 6 months. All the ribs metastasis subsided. But a year later, she succumbed to her disease. So it's a nasty, unfortunately nasty disease. Two major challenges to repeat localization in Cushing disease and preservation of the gland and management of recurrence. I thank you for your attendance, and I hope I cover some of the aspects. Thank you.
Thank you very much for another excellent talk. Thank you. Let's have some comments or questions from our panel, please.
Dr. Kaanan, wonderful talk. Wonderful talk as always, talking about this difficult topic of Cushing disease. Well, actually, there is some concern regarding, in some cases, the exact side of the tumor, because sometimes taking into account that sometimes we have bilateral tumor and sometimes we can have disease in one side and the other one, the contralateral one, can be just a non-producing tumor. So according to that, we have been using, and Professor Laws knows about that, we have been using the PET with methionine that seems to have some predictive value just for the location of the tumor. We use that in de novo cases in Cushing disease. We use that in recurrent cases in Cushing disease, and we also use that in this technique in recurrent acromegaly in macroadenoma tumors. Sometimes you have some extension, big extension of the tumor, you make the removal, and you have some hormonal recurrency, and you have an MRI with some scar, and you are not able to identify a small recurrent lesion. So, and we are very happy. We are just in the process of analyzing all our cases, because we have been using that for more than 10 years, and hopefully we can show the results very soon.
Great.
Thank you. I think it's a very interesting technology. Any other comments on this or any of the other talks?
Sanjeeva, this is Fred. Can I ask Imad? So Imad, just you have a patient with Cushing's classic, proven biochemically, beautiful little lesion that you see on the left side, as an adenoma. You go in and you find it beautifully. Do you explore the other side of the gland in those cases where you have? Because that's a question that's always asked, that but you should always explore the entire gland because you don't know if there's another one. What's your philosophy on that? Yeah. And I would ask Ed Laws, who has had a lot of experience with that.
Myself, I go where the stake is. There is a lesion, I go after the lesion. If there is no hint of involvement on the images and lateralization is very clear to one side, I go on only that side, because my other issue is the preservation of the function of the gland. This incision is not without an impact on the gland. If it's unnecessary, I don't do it, and that's what I'll do usually.
So,
Imad, could you unshare your screen just so I could see if people are putting their hands up, please?
Maybe I could tell you a little bit of what we've discovered over the past year or so, and that is we've had a number of patients that had obvious lesions on the scan, and they most of the time done well. And I do explore the entire gland, no matter what I find, and take out every bit of suspicious material. But what we've discovered is that we have patients with what are called hyperplasia. Now, hyperplasia is under the microscope and with our colleagues in neuropathology, hyperplasia is segments of the corticotroph cells just weaving their way through the normal gland. Often, there'll be a hypointensity in the region of these areas of hyperplasia. The problem is that they're indistinct from tumors. You can't do an extracapsular removal of a hyperplastic lesion. You have to take the rim sometimes of a capsulated lesion. You have to take a little bit more. And with regard to hypopituitarism, I think if you can avoid diabetes insipidus, that's really critical. But you can replace every other hormone easily and not expensively. And so if you have a suspicious area, you can remove it as long as it doesn't produce diabetes insipidus, and you can analyze what hormonal dysfunction the patient may have and fix it. What you can't fix is excess cortisol. And Reinke says, my friend in Munich, who's the best endocrinologist for Cushing's I know, every day a patient with Cushing's has too much cortisol circulating as a death warrant. It destroys the patient. And so you have to take every opportunity to get the cortisol normal, no matter what. And if you don't, the patient's going to have a terrible outcome and a recurrence, and you're in trouble. So that's what I've discovered about Cushing's. It's the most difficult thing we do. And if we have the problem of hyperplasia, which we really don't understand what the mechanism is at all, we have that as a problem, along with tumors that are hard to find, along with extracapsular dissections that don't always work because there's sometimes tumor not within a capsule. So it remains the most difficult thing we have, but always think about the patient. How sick is this patient? What's her life going to be like? Can you make it better? Can you do everything you can while you're there to make it better the first time? And you think about a hypophysectomy. We hardly ever do that anymore because it produces diabetes insipidus if you do it correctly. So we don't have the answer to this. And it's only been since Mini G. We still don't know.
I have one question. Sorry, let me, in that context, ask Ed. Ed, you said if you have a suspect, but we are talking imaging where unilateral. Inferior petrosal, unilateral. There is nothing, it's completely lateralized. You said suspect on seeing the gland from outside, how we would suspect and make the incision in the gland on the contralateral side, based on what we suspect hyperplasia where we have a lesion. Well defined.
I don't know how you can surely demonstrate hyperplasia. It does often look different from the normal gland. Okay. I try to enter the lateral lobe on the side that we leave behind with a soft curette and feel the tissue and look at it. And I do look at everything if we find a typical tumor and everything goes well. But it doesn't always work. I wish it did.
May I say something?
Yes,
yeah, Professor Falbush.
I completely agree with Ed. So it's independent what we are doing from the MRI finding, because half of the patients don't have a positive MRI and you have to look around. So that is one thing. Don't be orientated for the MRI. And these tumors are not always round circumscribed. They can have two nodules, one on one side, one on the other side, small connection in between, just in front of the posterior lobe, just in front normally. And then, of course, as Imad said, they can be also extraglandular, starting at the surface of the gland, going to cavernous sinus, even outside, or up to the diaphragm, or of course, down in the cellar floor. So I totally agree with Ed. You have to explore the whole cellar content, go around the pituitary gland, even below the diaphragm, look if there is something else. And of course, the problem with the hyperplasia does really depend on your special experience. It's different, I would agree. It's firm, but it's different from the firmness of the pituitary gland. And if you see that going, and if you produce hypercortisolism, that's no problem. It's more important to eliminate hypercortisolism. I totally agree with that. Thank you. A short question. The most aggressive tumors I've seen are those who are converted from a silent ACTH-OMA to a real ACTH Cushing's. When they are invasive, practically nothing helps. What is your experience?
So Sanjeeva, if I can just say one more thing. Cushing, we all know how incredibly difficult, and we've seen that very nicely. Imad saying, one of the things that I can never understand, and I think a lot of knowledge we don't, is, I have a patient that I operated on, 10 years ago with a Cushing. Nice, immediate drop. Remission, not cure, but remission. Now that patient is in remission for 7 years. And then he has recurring Cushing. So I talked to my endocrinologist. I said, so just explain to me, what the situation here. He said, of course, you left 2 cells. And those cells now. So I said, what are they doing in 7 years, those 2 cells? And so I have a belief, and I think, in terms of looking at the molecular profile, that these may be new tumors, that these patients have a defect in their genetic, makeup, that we see in a one that has had a remission for 10 years, then has another. That is not the same tumor. I believe it's another tumor that this patient is predisposed to getting Cushing. Now, I don't have any data for that, and we have to look at the molecular, studies on that. But I just still don't understand these long-term remissions and then a recurrence. And sometimes they're not in the same place. They're on the opposite side. That I think gives more thing to my theory. So that's just a comment that I want to make in terms of us not understanding really Cushing's very well at all.
Any other comments from anyone from our panel? Professor Benes.
Imad, thank you. It was excellent, and actually the whole afternoon was excellent. One question, you said, unfortunately, we do not have Gamma Knife, but CyberKnife. We are installing CyberKnife now. Could you expand on that a bit, please?
CyberKnife is another stereotactic knife. You see, radiation oncologists, they like it because they can treat many other organs. This is the comparison as Gamma Knife. When we want to bring Gamma Knife, it will be under the control of neurosurgeons. This is a political issues that always they fight it. And the other things, you can treat head and neck. They extended the neck in the recent years. But you cannot treat pancreatic cancer. You cannot treat any lung metastasis with the pulsation of the lung and inspiration, expiration. And so they feel it's a more cost-effective for them, and they cover a wider disease categories.
That I understand.
But you can give
effectivity.
See, the difference in the drop of the radiation beyond the lesion is almost similar. People has dealt with Gamma Knife, they feel the precision of Gamma Knife more, but in the recent papers, they are almost equal. The best drop of radiation is the proton beam. But who is having proton beam? I think this is very expensive tools. And now a report came, I think 2 days ago, from that neurologist, I think an endocrinologist in India during the meeting. She presented the worst outcome was the proton beam regarding the preservation of the normal functionality of the gland in her report, as compared to Gamma Knife or to the fractionated CyberKnife or conformal radiation. So conformal radiation turned to be, in her study, was the best for the pituitary gland functionality outcome. So this
I
is
see.
how I see.
So
But
you are happy with CyberKnife. Your main complaint is that you are not the owner of the Gamma Knife. Am I right? You are a CyberKnife.
yeah, you see, they used to call us for the cases. Now we refer the cases, they will do this. We used to draw to them the lesion and decide where we want to give validation. We want to be sure.
So should you operate the CyberKnife, you would be happy with it?
Yeah.
Yeah, okay.
Yeah.
I just could add something on a proton beam. We have one in Prague, you know, we do not operate it, but I can tell you that since it's in operation, never ever before did we see so many radio necrosis.